So, Assalamualaikum warahmatullahi wabarakatuh and a very good morning. So can everyone hear me clearly?
Yes.
Okay, thank you. So for my seminar, I will be presenting about meningitis and encephalitis. Macam ni. Okay, so for this is the outline of my presentation today. So first I will be introducing about meningitis and encephalitis, and then I will discuss about the etiologies, epidemiologies, pathophysiology, signs and symptoms, investigations, the complications of meningitis and encephalitis, and then last but not least, the management. And then, so first the introduction. So what is meningitis and what is encephalitis? So meningitis basically means that it is the inflammation of the meninges. So what meningeal layer consists of three layers, which is dura mater, arachnoid mater, and pia mater. So any inflammation of these three layers are considered as meningitis. And for encephalitis means inflammation of the brain parenchyma. So it affects the tissue themselves. The inflammation affects the tissue themselves. Next is the etiologies of meningitis and encephalitis. So there are many etiologies of meningitis and encephalitis, and I might not have listed all of them, but I believe that I've covered most of the etiologies of them in my slide. So the most common etiology of meningitis in pediatrics is bacterial. So I've divided it towards the age group. So for neonates to 3 months, the most common bacteria that causes meningitis is group B Streptococcus, Escherichia coli, Listeria monocytogenes. And for 1 month to 6-year-old, the most common organism is Neisseria meningitidis, Streptococcus pneumonia, Haemophilus influenza. And for children more than 6 years old, it is caused by Neisseria meningitidis and Streptococcus pneumonia. There are also other causes such as viruses and others such as parasites, fungus, autoimmune, and drugs. So for the viruses, the most common is enteroviruses, Epstein-Barr virus, adenovirus, and mumps virus. And for the others is Borrelia burgdorferi, which causes Lyme disease, Bartonella henselae, which causes cat scratch disease, Mycobacterium tuberculosis, Toxoplasmas, fungi such as Cryptococcus, Histoplasma, Destomycosis, parasites such as Naegleria fowleri and Acanthamoeba. So for autoimmune cause of meningitis is rheumatoid arthritis and systemic lupus erythematosus. And for the drug cause of meningitis is metronidazole, non-steroidal anti-inflammatory drugs, and IV immunoglobulin. So as you can see, there are like two color of the boxes, right? So the boxes that is orange in color means that it is infectious. And for the white color it is non-infectious. So next we move on to etiology of encephalitis. So the most common cause of encephalitis is caused by viruses. So the viral cause is herpes simplex virus type 1 and 2, or varicella zoster virus, Epstein-Barr virus, West Nile virus, and influenza virus. And the last common virus that causes encephalitis is respiratory syncytial virus, human metapneumovirus, COVID-19, measles, which causes PIE and SSPE. So PIE is post-infectious encephalitis, which means that after the patient had been infected by measles, there is abnormal immune response that causes the immune response to attack the myelin sheath, while SPE is almost the same, but it occurs in a slower manner. And then for the non-viral cause of encephalitis is Borrelia burgdorferi, Bartonella henselae, Chlamydia, Mycoplasma pneumonia, Listeria monocytogenes, and Mycobacterium tuberculosis. So it is also worth noting that non-viral causes of encephalitis usually also will cause meningitis, which we call as meningoencephalitis. And then the epidemiology of meningitis and encephalitis. So the most common cause of meningitis is bacterial, like I've mentioned before, and the highest risk is newborns who are less than 1 month, and the second highest is infants, which is 3 to 8 months. And the most common cause is Haemophilus influenza, Streptococcus pneumonia, and Neisseria meningitidis. So overall, meningitis, there are 1.2 million cases per year worldwide. So why is meningitis so heavily is very important because without treatment, if it is not treated, the mortality, which is the fatality rate of the patient, which the patient is 70%, which means that 70% will die if it is not treated. And then the morbidity is, even though the morbidity, even though there are like 30% that survive, right? One in the five survivors are left with permanent neurological sequelae. Sequelae means the after effect or the aftermath. So the example of neurological sequelae is hearing loss, neurologic disability, and next is the encephalitis. So overall, there is 4 to 10 cases per 100,000 patients per year in pediatrics, and the incidence is slightly higher than in male, and incidence is high in pediatric population. It is highest among infants less than 1 year old. The most common cause of sporadic encephalitis in the United States is herpes simplex virus. And outside of United States, the most common is Japanese encephalitis. And in Malaysia, Japanese encephalitis, WHO has reported in 2016 that there are a total of 59 cases that year. And even though it is like commonly known in Malaysia, it is not considered a major public health problem except in Sarawak, because in Sarawak, the mortality rate of Japanese encephalitis, even to be treated, is 9%. And then this is the pathophysiology of because the most common etiology of meningitis is bacterial. So I specified the pathophysiology to bacterial meningitis. So for bacterial meningitis, there are like a predisposition of predisposition. Some condition that causes predisposition towards meningitis. For example, immune deficiency, prolonged close contact with infected patients, and travel to endemic areas. So there are a lot of organisms, and when these organisms gain entry into the body, they occur via various mechanisms, because we know that different bacteria have different mechanism of entry, right? So for example, there are invasion of mucosal surface, which is, for example, respiratory tract, for example, strep pneumonia and Haemophilus influenza. And then there are some bacteria that spread from parameningococcus, which means that from sinusitis, it causes otitis media, and then causes mastoiditis, and then spread to meninges. And there also penetrating head trauma, which will introduce the pathogens themselves, and anatomic defects in the meninges, such as skull fracture, and also previous neurosurgical procedure. And in this host, bacteria can enter the central nervous system and colonize the meninges, and especially the arachnoid layer. So it causes bacterial meningitis. Next is the pathophysiology of encephalitis. So the viruses replicates outside the central nervous system, and then they travel to the central nervous system via hematogenous spread or neural pathway. So the virus enters neural cell and causes disruption in cell function, perivascular congestion, hemorrhage, and also diffuse inflammation. So next, we move on to sign and symptom of meningitis. So the sign and symptom of meningitis. So for the symptom of meningitis, there is a classic triad, which is fever, headache, and neck stiffness, or sometimes we also call it nuclear rigidity. And also there is also symptom of increased intracranial pressure, for example, altered mental status, nausea, vomiting, sleepiness, and paradoxic irritability. So paradoxic irritability means that usually when baby are held, they shut up. They feel calm, right? Baby are calm when they are held, and they will cry when they are not held, like they are being ignored, right? So paradoxic irritability means that the baby will cry when they are being held, and will be okay if they are being ignored or something like that. So for the sign of meningitis is there will be sign of meningism, which is opisthotonous, chronic sign, Brzezinski's kind, and also sign of increased intracranial pressure, for example, bulging fontanelle, papillary edema, and sunset eyes. So this is an example of the sign just now. So this is the opisthotonous position, which can be seen as the arch back and the hyperextension of the neck muscles. So, and then the chronic sign. The chronic sign is a positive chronic sign means that if one of the patient's leg is held at 90 degree and you try to straighten it, they cannot straighten it because yeah, they will feel pain or something like that. And for the bruising skin at sign, a positive bruising skin at sign means that if you lay a patient on a supine position and you tilt the head up, the leg will also go up. And the same will occur, it will also be the same if you lift the leg, the head will also go up. So this is sunset eyes. So sunset eyes is caused by upward dysparesis, which means that there are some cranial nerve involvement, and this is the bulging fontanelle. I'm not sure if you can appreciate it or not because the picture is quite unclear, but I've tried to find a clearer picture, but I cannot find any. So these are the signs and symptoms of encephalitis. So the symptoms is fever, nausea, and vomiting, altered mental status, personality changes, movement disorder, irritability, photophobia, flaccid paralysis. This is my mistake. I should put it under signs. There is also night stiffness and lethargy. And for the signs, because we know, I've mentioned just now that the encephalitis is usually caused by virus, and the most common the most common virus that causes encephalitis is herpes zoster. So we see for any signs of herpes virus infection such as hepatitis, skin lesions, and conjunctivitis. And then these are just the others are just symptoms of increasing intracranial pressure, which is seizures, bulging fontanelle, meningismus, and also spastic paralysis, and also flaccid paralysis. And flaccid paralysis is usually seen in West Nile encephalitis and also Japanese encephalitis. So for the investigation, what can we do to investigate the patient is full blood count, blood urea, serum electrolyte, random blood glucose, urine streptococcal pneumonia antigen, lumbar puncture, and herpes HSV DNA PCR. So for the full blood count is we just want to see the neutrophil count and whatnot. And then for the random blood glucose, because we know that in bacterial meningitis, there will be slightly there will be a lower blood glucose compared to lower blood glucose in CSF compared to blood. So we compare the random blood glucose to the glucose content in the CSF. So the urine streptococcal pneumonia antigen is just to rule out or to diagnose streptococcus pneumonia meningitis, and lumbar puncture is to see the result and whatnot. So for the neuroimaging, we can do CT scan, ultrasound, MRI to ensure what's happening. And if you suspect TB, tuberculosis, we do chest X-ray, mental test, and also interferon gamma release assays. So these are the CSF findings that can be seen in meningitis and also encephalitis. So for the acute bacterial meningitis, the leukocytes count is usually 100 to 550,000 millimeter per mil. So the protein is usually 1 to 5, glucose is less than 0.5 or 1.5, and if you do microscopy, the gram stain may also be positive. And the partially treated bacterial meningitis, there is slightly lower leukocyte count. The protein is more than 1, glucose is low, and this CSF might be sterile in pneumococcal or meningococcal meningitis because so there is also tuberculosis meningitis. The leukocyte count is low, and there are also seen polymorphonuclear cells. The protein is usually 1 to 5, and the glucose is also 0 to 2. So if we suspect tuberculosis meningitis, just as I said right now, just now we do mental test and also smear for AFP. And for fungal meningitis, the leukocyte is also 50 to 500. The protein is 0.5 to 2. The glucose is normal or low. And if we do CSF culture for cryptococcal antigen. And for encephalitis, the leukocytes is usually 10 to 1000. Protein is normal or 0.5 to 1. The glucose is normal. So if we suspect encephalitis, we do CSF virology for HSV and PCR because the most common cause of encephalitis in child is herpes simplex virus. So these are the complications of meningitis and encephalitis. So meningitis, the complications: seizures, cranial nerve palsy, ocular effusion, cerebral edema, transtentorial herniation, non-obstructive hydrocephalus, which means obtundation, metal retardation, syndrome of inappropriate antidiuresis hormone, uh, and there is also a cases of disseminated intravascular coagulation. For complications of encephalitis, there will be motor deficit, seizures, recurrent seizures, cognitive and memory deficits, changes in mental status, and also there is also the same complication as immobilization, which is disseminated intravascular coagulation and diabetes alba and etc. So these are just I've taken it from Kagari guide just to explain the how the complication occur. So for example, for seizures, we can see that the bacterial meningitis causes the inflammation of the meninges and it irritates adjacent cerebral cortex, so causing hypersynchronous neural activities and causes seizures. And for the cranial nerve palsies, the inflammation causes the cranial nerve to be irritated. For cerebral edema, because there are inflammation of the meninges, there is a higher probability of blood-brain barrier and causing fluid extravasation. And also, when the cerebral edema worsens, it causes transtentorial herniation because there is increase in intracranial pressure. So there will be also communicating hydrocephalus, in which the arachnoid granulation blocks cerebral spinal fluid from draining into the vein. And then there is also other complications. For example, infection of cerebral arteries by bacteria causing meningitis can cause vasculitis, and vasculitis causes that lower blood flow to brain parenchyma and cause ischemic stroke. And then it can also cause high blood pressure, and the blood can rupture, and it can cause hemorrhagic stroke. So what it can cause is hemiplegia, hemiparesis, seizures, and syndrome of inappropriate antidiuresis hormone secretion. So SIAD only occurs if pituitary is involved, and if bacteria gain entry into brain parenchyma, it can cause brain abscess. And this is if the bacteria meningitis. The third one is if the bacteria goes into the systemic circulation, it can cause sepsis, and the sepsis can cause DIC and cause organ failure. I think that's all for the complication. And then next we move on to management. So what we do in patient with encephalitis and meningitis is first we give supportive measures. We monitor temperature, BP, pulse, and 4-hourly. So if there are any symptoms or signs of any systemic complications such as hypovolemic shock, hyponatremia. Hyponatremia is usually caused by SIAD. So we need to treat that complications first. And if because it is inflammation of the brain, some patient might go unconscious. So we need to manage by nail by mouth. Nail by mouth is means that we feed the patient by a feeding tube. And then we manage the fever and pain. We do seizure charts and do daily neurological assessment. And then there are if the patient experience certain symptoms, we can do subdural drainage. So for example, if the patient have rapid increase in head circumference with no hydrocephalus, and there are also focal neurological signs of increased intracranial pressure, and also suspected subdural empyema. So next we do follow up. So we note the developmental of the child, we note the head circumference of the child, and we note for any behavioral abnormalities in the follow-up. We also assess vision, speech, and hearing of the child. So we follow up until the child is shown to have normal development. Usually the child, we follow up until 4 years old of age. And next, for the management is we can also administer steroids towards patient with meningitis and encephalitis. So meningitis, we administer steroids to reduce the sequelae of bacterial meningitis. How? Because we see that the meningitis is inflamed because the host immune response causes inflammation, right? So the steroid attenuate the host defense system, and so there will be less inflammation. So the most common steroid used in Malaysia is dexamethasone. However, dexamethasone is not recommended in neonates. Next is the drugs. We can administer drugs to the patient. So for the meningitis, upon suspicion, even though we didn't even confirm the diagnosis yet, we need to administer antibiotics because we see that the meningitis have poor outcome, right, if treated late. So we administer antibiotics upon suspicion. So in child, less than 2 months, we usually administer cefotaxime plus benzopenicillin, and more than 2 months, we administer cefotaxime plus vancomycin if there are gram-negative cocci is seen in gram stain. For encephalitis, the most common is sulfasalazine plus, right? So we administer drugs such as acyclovir. I think that's all for my presentation. Are there any question?
Is there any question from the floor? Can all of you hear me or not?
Yes, we can hear you, Doctor.
Okay, so yeah, so any question on the floor? Okay, so this okay, for meningitis, pathophysiology are very straightforward. Okay, so it's very good that you came out with the list of cause, meaning you list out your bacteria, viral, and then non-infection cause like SLE. Okay, so yeah, this one. So actually, this is an important slide for you to understand because especially meningitis, because you see neonate to 3-month-old, the organisms are very much different from those that beyond neonatal age group. Okay, so if neonatal age group still GBS, so group B Streptococcus is still the commonest. Okay, as the child grow bigger, then you will start to see Haemophilus, Streptococcus pneumonia. Then if bigger, more than 6, usually it's just strep pneumonia. But however, there are also other possible agent as well. This is the only commonest agent that you listed. Okay. So encephalitis, yes, most common is virus, but usually it's herpes simplex virus. Okay. Varicella zoster, Epstein-Barr, those are quite rare to causing encephalitis. Okay. So after you talk about, then the route of entry, that one I think is also very straightforward. This how the agent get into the brain. So it's either via hematogenous spread or direct inoculation from the local site. Okay. So once they go in, then they will cause problem. I think the most important for you all to understand is what type of problem they will cause. Because just now, I think the presenter has a big difficulty in talking about what is irritability. Irritability, not you put the child there, then the child just shut up like that. No. So irritability is the best person to tell you is the caretaker, meaning the mother or the father or the guardian that take care of the child all the time. They would be able to tell you that whether the patient irritable or not. But you need to ask a very good question, because if you just ask, anak you nangis macam tu ke? And you say, ada lah nangis macam tu. So doesn't mean anything. So you need to know what to ask. So like, is your child normally cry like this when they unwell or not? Or do you feel that your child cry most of the time this time? So these are the things that will alert the caretaker so that they can give you, can tell you, yeah, maybe mungkin anak saya tak biasa lah nangis macam ni nangis tak henti-henti. Then you know this is not normal. Okay, so this is irritability. Why I have to highlight this? Because a lot of the junior doctors are having difficulty also to identify irritability. Okay, recently we also encounter a patient with intracranial bleed coming irritability for almost 1 day but not pick up. In the end, patient didn't make it. So take very heavily regarding the irritability. Then the rest, your fever, headache, it depends on the age of your patient. If your patient is very young, they cannot tell you the headache. Headache is only demonstrable, or you can ask for the child that can talk. Okay, so irritability is something that you will really notice, or the parents will really notice it. Okay, then of course your clinical sign, is the presenter know why you will have all these Khean sign, Brzezinski sign, due to what?
I'm not sure, doctor.
So all the sign that you try to elicit is because there is meningism, meaning meningism all over your CNS, which include your spine. So if you want to flex your lower limb, flex your head, so those are causing turning or twisting, flexing your spinal cord. So they will feel pain because the inflammation occur there. Same goes to if you have inflammation on your leg, you also don't want to move your leg, isn't it? So it's the same finding. It's not because of magic that you do this, then the patient will do that due to meningitis. It's due to the meningism. Of course, the abnormal posture is also a sign of pitotenus, is a sign of cerebral compromise. Okay, so this also must be. Sometimes this also will mimic like a seizure. So for those that of you might think arching of back and the child in very stiff position, this can be mimic a seizure. Outward gaze paralysis usually is very late unless the patient have hydrocephalus. In this picture also it shows hydrocephalus. The forehead is very big. Okay, of course anterior fontanelle would be bulging. Okay, so otherwise I think regarding clinical sign, the other thing you have to highlight is outer sensation, your outer mental status in all encephalitis and meningitis. Although you put in the symptom, but that actually is a clinical sign that you have to look for. Outer mental status in symptom is whether the child confused, whether had change of behavior. It should be outer behavior, not outer mental status. Outer mental status, it should be a clinical sign. And then as your sign that you put, most of them are real sign, but there's no mental status, although you're still talking about CNS problem. Okay, so but I think the rest of the presentation are okay. Yeah, so to me, actually, the most important part for meningitis and encephalitis is always has high index of suspicion for your patient that presented to you with fever, outer mental state, outer behavior with seizure, plus minus seizure or irritability. Because then the next, I think your friend will talk about febrile fit, right? So that is an important thing that you all need to learn how to differentiate, because the treatment is different. If you delay treatment in meningitis, your patient can end up with sequelae and is irreversible. Okay, so the management part, I think I would not comment on it, although I think as times go by, you all will know more. Okay, if there's no question, then shall we move on to the next presentation?
Thank you, Doctor.
Okay.
So, can you all hear me? So, my name is Nosara Fizana Bitumbara, metric number 1911868. So, I would like to present about febrile seizure and epilepsy. So we start first with epilepsy. So seizures is a abnormal excessive synchronous electrical activity that occur within CNS that can lead to occurrence of sign or and symptoms. So for epilepsy, epilepsy is recurrent and unprovoked seizures, or at least 2 or more unprovoked seizures occur more than 24 hours apart, or 1 unprovoked seizure and a probability of further seizures similar to general recurrence risk after 2 unprovoked seizures occurring after next 10 years. So epilepsy is the most thing here is recurrent, which is occur more than once, and unprovoked seizure, which is means that no causes or idiopathic causes. So next is this is the classification of seizures. So we have focal onset, generalized onset, and unknown onset. So focal seizures means that it involves only one hemisphere, cerebral hemisphere, and generalized onset involve cerebral hemisphere. So focal seizure, it comes with awareness or without awareness. So for types of seizure, the first one is tonic seizure. So tonic seizure are associated with muscle stiffening or increased muscle tone. So it may cause the person to fall, often backwards. And next is atonic. So atonic seizures, also known as drop attacks, are characterized by a sudden loss of muscle tone, and it may cause the person to collapse or drop down. And clonic seizures are associated with rhythmic jerking muscle movement. So the most affected one is the muscles of the neck, face, arms, and legs. And tonic-clonic seizures is the most common generalized seizures. So the person will come with tonic phase first, which is the stiffening of muscles, and the clonic phase, the muscle jerk. And then myoclonic is short muscle twitchiness, and absence seizures. Absence seizures occurs most often in children and is characterized by a brief of loss of awareness. So usually manifested as blank stare with of without subtle body movements such as lip smacking or eye blinking. So for the pathophysiology, seizure occur when there is imbalance between the excitatory pathway and inhibitory pathway. So either one, it can lead to increase in action potential that can make the neuron fire at the same time in a large number of neurons. So how to approach a child with epilepsy? So first, we need a detailed history of seizures, such as where the seizure occurred, the child's behavior before, during, and after the seizure occur, and also other histories such as birth, past medical, developmental milestone, and family history. For physical examination, so we should perform general and system examination thoroughly to look for clues of underlying etiology, because epilepsy is unprovoked seizure, meaning that there's no cause. So we should find other do physical examination thoroughly to look for other causes to rule out the epilepsy itself. So for investigation, so full blood count and biochemical investigation are conducted to exclude the metabolic causes and before starting the anti-epileptic drug therapy. While EEG, electroencephalogram, is important to support the clinical diagnosis of epileptic seizure, classify this seizure type and epileptic syndrome, and helps in selection of anti-epileptic drug. And for neuroimaging, CT scan is indicated only for seizures in emergency setting during acute illness, while MRI is indicated in epilepsy that occur in the first year of life, except for seizure. And if there is difficulty in controlling the epilepsy. So for principles of anti-epileptic drug therapy, so this is how to treat the epilepsy. So first, we need to classify the seizure type and epilepsy syndrome, and start treatment if there is more than 2 episodes, and we should do monotherapy as far as possible. So we should choose the most appropriate drug based on the epilepsy syndrome, the seizure type if epilepsy syndrome is not identified yet, and associated comorbidities. So we should gradually increase the dose until the seizure is controlled or maximum the doses or maximum dose reached, or if the side effects has occurred. So we should add on the second drug if the first drug failed and optimize the second drug just like we did for the first drug, and then try to withdraw the first drug. So these are the list of anti-epileptic drugs based on the epilepsy syndrome and also according to the seizure types. So for intractable epilepsy means that the seizures cannot be controlled by the medicines. So when this happens, we need to reevaluate whether the event was really a seizure, whether the event was really a seizure, or did we classify the seizure or epilepsy syndrome correctly, or does the patient compliance to the therapy, or if the therapy itself causes the seizure. So if there are these possibilities, we should change the medicine correctly. So next, we go to the febrile seizure. So febrile seizure are seizure that occur between the age of 6 and 16 months with a temperature of 38 degrees Celsius or higher that are not the result of central nervous system infection or any metabolic imbalance, and that occur in the absence of a history of prior febrile seizure, meaning that the patient does not have any history before she get the febrile seizure. So for the classification of seizure, febrile seizure. So febrile seizure is divided into two classification, which are the simple febrile seizure and complex febrile seizure. So for simple febrile seizure, it usually manifested as generalized seizure. The most common one is tonic-clonic seizure. So the first is muscle stiffening, and then the rhythmic muscle point, rhythmic muscle jerk. For complex febrile seizure, it usually manifested as focal seizure. So it can come with tonic or myoclonic seizure. And simple febrile seizure usually lasts less than 15 minutes and occur only once in 24 hours, while complex febrile seizure, it lasts longer than 15 minutes and can occur more than one within the 24 hours. So for the post-ictal phase, so post-ictal phase is it started after the seizure has subsided. So the symptoms are like confusion and drowsiness. So for febrile seizure, the post-ictal phase usually is not prolonged post-ictal phase. So if there is prolonged post-ictal phase, it may be a sign of other etiologies. So for the epidemiology, so there is no comprehensive local epidemiological data for febrile seizure, and in Western Europe, 3 to 4% of children less than 5 years old will experience febrile seizure. But in Malaysia, there's study in 1994 involving 117 children. So the boys to girls ratio was 1.5 to 1. So meaning that the the boys will likely to have febrile seizure than the girls. So there is 92.9% of febrile seizure that occur before the age of 3 years, and the highest number of febrile seizure was in the 6 to 12 months of age group. And 33.3% of the children that experience febrile seizure has complex features. So for the pathophysiology of febrile seizure, the underlying pathophysiology is unknown, but some factors can contribute to febrile seizure, such as genetic susceptibility and viral infection, immunization, and high fever. So for the diagnosis, actually to diagnose the febrile seizure, we need to evaluate the source of fever. So we need a detailed history and a thorough physical examination. For the history, we need to ask whether the child has a recent viral infection, the child has immunization, or the child has a family history of febrile seizure. So for physical finding, need to look for the level of consciousness, because if the level of consciousness is prolonged, so it means that this is not febrile seizure. And we should also look the meningeal signs such as the Brudzinski sign, Khean sign, or neck stiffness. And for viral examples, is the eruptive skin rash that can that caused by viral infection, mostly such as the common one is the measles, the rubella, rosella, and also chickenpox. So we should look for the physical signs so that can be rule out the febrile seizure. So these are the Brudzinski neck sign and the Khean sign. So for lumbar puncture, lumbar puncture must be done in all infants younger than 6 months of age who present with fever and seizures, because meningitis must be suspected in a baby with fever, especially in babies less than 1 month old. So because if like Brother Iqmal has said just now, so meningitis has poor outcome. So if we diagnose it fast, so we can treat it quickly. And then if there is any sign or symptoms that suggest the presence of intracranial infection, such as the meningeal sign, or if the child has the persistent lethargy and not fully interactive, lumbar puncture also should be considered to do in the age of less than 12 months old, especially if the child has not received Haemophilus influenza B and pneumococcal immunization or unknown immunization status, because they may be lack of abnormal neurological sign in the child of this age, and also should be considered to do in the prior antibiotic therapy. So because antibiotic may be insufficient to eradicate meningitis and may mask the signs and symptoms of the disease. So other investigations such as complete blood count and measurement of serum electrolyte should not be routinely performed solely for the diagnosing of febrile seizure. If you want to perform it, you should perform because you want to find the source of fever and not the cause of febrile seizure itself. So for the prognosis of febrile seizure is excellent because it is benign, and although it can recur in 30 to 50% of the children, actually the intellectual achievements are usually normal, and there's about 2 to 7% of risk developing subsequent epilepsy. There is like neurological examination or development, family history of epilepsy, and also complex febrile seizure. So next is the risk factors for recurrent febrile seizures. So febrile seizure can recurrent if there is a family history of febrile seizure. The febrile seizure occur in the child age of less than 18 months, low degree of fever, less than 40 degrees Celsius during first febrile seizure, and also a brief duration, less than 1 hour between the onset of fever and seizure. So the more the risk factors of recurrent febrile seizure you have, so the likely you will have the risk of recurrent. And next is management. For management, not all children need hospital admission because we want to exclude the intracranial pathology, especially infection, and we also fear of recurrent seizures. And parents should be counseled on the benign nature of the condition, and we should control the fever in the febrile seizure. So we should avoid excessive clothing and use antipyretic such as syrup and paracetamol for patients' comfort, but antipyretic does not reduce the recurrence of febrile seizure. And parents should be advised on first aid measures during seizure, such as do not panic and remain calm during the febrile seizure, and note the time of onset of the seizure. Not insert any object of the mouth into the mouth even if the teeth are clenched, and do not give any fluids or drugs orally. So for rectal diazepam, So rectal diazepam should be supplied to parents of children with high risk of recurrent febrile seizure, and the parents should be teach on how to administer the rectal diazepam if the seizures last more than 5 minutes. And for prevention of recurrent febrile seizure, so do not give anti-epileptic drugs, because anti-epileptic drugs they have more side effect than the benefit to control the febrile seizure. And because febrile seizure, the prognosis is excellent and the outcome is the intellectual achievement, the outcome is very is normal. So we should not give the anti-epileptic drugs. So I guess that's all from me.
Okay, any question from the floor?
I have question. My name is Masradi. Can I ask? My question is about the definition. Yes, yes, doctor.
Yeah.
My question is, the definition is to diagnose epilepsy, it is an unprovoked seizure more than one times. Unprovoked seizure mean does not cough or fever or anything, or just unprovoked means suddenly a seizure, or what does mean by unprovoked seizure?
Unprovoked seizure means that the seizure occurs suddenly without any causes. So like I said just now, you should take the history and physical examination thoroughly. So if there is neck stiffness or chronic sign like chronic sign breathing kiss kind, so it is not simple febrile seizure, or it is not febrile seizure. So it means that the meningitis itself caused the seizure, not the febrile seizure itself. Understand?
Okay, thank you.
Yeah, I agree. Actually, unprovoked, as the name implies, is unprovoked, means nothing happened prior to that, patient develops seizure. Of course, other than your history taking physical examination, you must also rule out electrolyte imbalance, example like calcium abnormality and things like that, okay? Actually, to me, epilepsy is a very big topic if you want to talk about it, but as a general practice that you need to know, yes, correct, you list out the semiology of the characteristic of the seizure, which is you can be generalized or focal seizure. Of course, other than that, you have absent seizure. So because you have to determine the semiology very well, because the treatment are based on, or treatment or the possible diagnosis are all based on the semiology. Okay, so then that's why you need to have a very good history taking for you to come to the diagnosis, because different type of seizure have different type of medication. Okay, if you read through PEACE protocol, if generalized seizure, they will suggest you to use sodium valproate or higher generation like levetiracetam. Of course, if you are partial seizure, then sometimes they will use lamotrigine or carbimazole, things like that. So it's a different type of management. Okay, so you need to determine the semiology very well. So then regarding the history taking, you mentioned need to know the semiology and all that, birth, but actually family history of epilepsy also is important. And then is there any consanguinity? Consanguinity means there's a blood-related marriage lah. Okay, that will also be important history, because certain group of diseases, genetic diseases in particular, are associated with inheritance from the family, especially is a consanguineous marriage. Okay, so then comes to the febrile fit. So febrile fit is the one that you all really need to understand how to differentiate between a meningitis and febrile fit. Okay, but febrile fit to me actually is a diagnosis of exclusion. Why I say diagnosis of exclusion? Because you have to exclude everything first, then only you can say this is simple febrile fit or complex febrile fit. Why I say like that? Because in practice, in future when you all do practice, because if meningitis, you need to treat early, right? I mean, you also mentioned in your slide, previous your friend also mentioned. So if your mindset to start with is to diagnose a simple febrile fit, then the treatment may be delayed. So that's why you really need to rule out meningitis for every single patient presented to you with fever and seizure. So that's why just now I also stress on the irritability, how you're going to ask and what are the things you look for during the physical examination. Okay, but regarding the classification of the febrile fit, they are simple and complex. Basically, simple means generalized, occur once in 24 hours, and then subsequently lasted less than 15 minutes. Subsequently, anything occur other than that is considered as complex. Meaning if occur twice or not and because just now when the slide you put on, I think some of your friends, I worry they might get confused because one is generalized, the other one complex you put focal. So it doesn't mean that generalized is not complex febrile fit. Okay, so you just have to remember what is the simple febrile fit. Anything other than that presentation is complex febrile fit. Okay, so then overall prognosis is good for febrile fit. So, but the recurrence are there. So once you have the first episode, you will have about 30% to develop the second one. Once you get the second one, you are about 50-60% to get the third one. Okay, so that's why the statistic you gave is at 30 to 50%. Okay, so usually we will admit patient during the first episode of febrile fit because you need to find out that the child truly is febrile fit or not. Okay, then subsequent fitting is based on your febrile fit education. Okay, which you might learn later regarding the febrile fit education. Sorry. Okay, so far I think those are things I would add. Any other burning question from the floor?
Doctor, I am Sakina. I want to ask, I've read the book that if there is an episode of seizure, we need to lay the child on the left lateral side. What is the reason for this? And also, if there is like the second attack, the mother should bring the child immediately right to the hospital, or as it is benign, just wait at home? Two questions, Doctor.
Okay. So for question number one is the management of seizure in acute setting is yes, you have to put the patient lay on the side, left lateral position, because the child might vomit. Okay, if any vomiters, you should clear up by that one, and then you should help to clear the airway as well. So that because patients are having seizure, most of the time they would not be able to protect their airway very well. So if you read acute treatment for seizure, they will ask you left lateral position, put oxygen, monitor vital sign, BP, pulse rate, SpO2, check temperature, do DX-TIM. Okay, so those are the standard. The reason behind is the child, you don't want the child to vomit and then the cause upper airway obstruction. Okay, so for the question number two, this go back to your febrile fit education. So if we want to talk about febrile fit education, we can spend another half an hour just plenty talking about febrile fit education. Okay, but overall, once you educated the mother that what to look for, what are the warning signs to look out for the child, if they are comfortable, they can stay at home if the mother is comfortable. But if the seizure lasting more than 5 minutes, I would still advise the mother to bring the child to seen by someone. Okay.
All right. Thank you, doctor.
Okay. Is there any other question? If no, then we move on to the next presentation.
I have a question, doctor. My name is Adam. So
Yeah.
when the presenter said that if the child have seizure, if they are less than 6 months, we need to do lumbar puncture. Is there a reason why we don't do for babies that are older than 6 months?
Okay, so presented fever with seizure, then we do lumbar puncture. Basically, if we go to clinical practice, it will still go case by case basis. Okay, so they would advise to do lumbar puncture if the presenting complaint and the child condition does not suggest of meningitis, also we might not do lumbar puncture also. Okay, so why they advise to do like that? Because sometimes the younger the children, the more difficult for you to assess the clinical condition of the child. Okay, so that's why they advise in such manner. Basically, to me, I still think if clinically suggestive, then only we will do lumbar puncture lah. Because we know if this simple febrile fit, we generally don't do. And it's not a blanket rule for it. Okay?
Okay, thank you, doctor.
Okay, any other question? Okay, then shall we move on?
All right, can you guys hear me?
Yes.
Right.
Yeah.
Okay, so Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Siti Najab Zamri, matric number 1912126. So inshallah today I will present about cerebral palsy. So we go for the name first. So cerebral palsy, cerebral, it refers to the brain. So brain disease, palsy that causing paralysis. So okay, so this is the content of my presentation today. I will go for introduction and then recap for a little bit about nervous system physiology and then the etiology and pathophysiology of cerebral palsy, as well as types of cerebral palsy, signs and symptoms, physical findings, diagnostic tests, and also management. All right, so for definition, so cerebral palsy is a disorder of tone, movements, and posture due to non-progressive lesion pathways in the developing brain. So this definition I got from Pediatrics. So I'm focusing to the developing brain. So cerebral palsy is a neurodevelopmental disorder, which means the cause of this disease is 70 to 80% due to prenatal period. So any event or any complications due to during that period can probably increasing the risk for having cerebral palsy. Okay, for epidemiology, this is the most common motor impairment in children, and the incidence rate is among thousands of live births, 2 of the children will be having are diagnosed with cerebral palsy. So the pathology that causing cerebral palsy is cerebral atrophy, parencephaly, and also degeneration of basal ganglia. Basically, the clinical features of cerebral palsy is highly related to the part of the brain that got damaged. So for example, if the cerebral got damaged, so the sign and symptoms is very specific to where the lesion is located lah, right? So you can refer to this diagram. So you can compare at the left side. It is the healthy brain anatomy. You can see the size, the difference of size between the healthy brain and also the cerebral atrophy. Okay, So this is the pathology that can cause the signs and symptoms of cerebral palsy. Okay, so this is the risk factor of cerebral palsy. So as I said just now, antenatal period is very crucial to make sure that there is no complications for the child if there is any. So it will increase the risk for the child to have cerebral palsy. So among the highest risk factor is prematurity and low birth weight. So this is the most common one, and there are also intrauterine infections, multiple gestation, pregnancy complications, and many other more. All right, and there will be also risk factor in perinatal and postnatal period, but it is less common than antenatal period. So in perinatal period, if the child having birth asphyxia, which means that the child having less oxygen, I mean there's complication where when the child is birthed, so there is less, the child receives less oxygen, so there might be a high risk for the child to having cerebral palsy and also complicated labor and delivery. So for postnatal, non-accidental injury, head trauma, meningitis or encephalitis, and cardiopulmonary arrest. Okay. So now we will move to classification of cerebral palsy based on motor function. So mainly there are few classifications of cerebral palsy, but now I will just classify cerebral palsy based on the motor function. All right. So the first one is spastic. So spastic cerebral palsy is the most common one, which is 70%. So it is damage to upper motor neuron pathway, which specifically pyramidal pathway. And the other one is ataxic, which comprises of 10% due to damage of cerebellum and its pathway. And then the third one is dyskinetic or athetoid, which comprises of 10% due to damage to basal ganglia and also extrapyramidal pathway. And last one is mixed. The child might having spastic cerebral palsy, ataxic, and also dyskinetic. Right, so you can focus on the diagram in the middle. So you can clearly see if the damage is occurring in the cortex, so most probably the child will manifest it with spasticity, with spastic cerebral palsy clinical manifestation. But if the damage or the injury occur at the basal ganglia, so the child might be having athetoid cerebral palsy, and as well as if the damage occurring at cerebellum, so the child might be having ataxic cerebral palsy. All right, so now we move on. So this is just recap, because nervous system is quite complicated, right? So I'll just recap regarding the function of different tracts. So we know that in order for us, for example, to move our biceps like this and to do whatever movement, we need the signals from our nervous system. So the signals needs this pathway and tracts so that it can reach our muscles. So this is pyramidal and extrapyramidal tract. It is part of upper motor neuron. So you can see the importance of corticospinal tract. It is for voluntary control body and corticobulbar tract for voluntary control for face, head, and neck. And then for extrapyramidal, it consists of lumbrospinal tract, vestibulospinal tract, tectospinal tract, reticulospinal tract, and all of these tracts are important for coordination, movement, and balance. So if there is any impairment or lesion in either of these tracts, so it will cause clinical manifestations of cerebral palsy. All right. Okay, so this is for cerebellar pathway. So we know that cerebellum functions to coordinate and plan movement and maintain balance. So same as just now. So it has its own pathway, which consists of spinocerebellum, vestibulocerebellum, cerebrocerebellum, and all of this pathway is important for coordination, balance, and etc. All right. So okay, I'll move on to pathophysiology because we have recapped the physiology of a little bit of nervous system briefly. So now I want to show you guys how does the clinical manifestations occur due to the pathophysiology specifically, right? So let's focus on this side, right? So any injury to either pyramidal tracts or extrapyramidal tracts due to lesion or anything lah kan. So for example, injury to pyramidal tracts, it will cause corticospinal tract damage and it will manifested as spastic cerebral palsy. So how does spastic cerebral palsy will be manifested? There will be increased tone, hyperreflexia, and also clonus. And if there is any injury to extrapyramidal tracts, so it will cause cerebellar damage and manifest as ataxic cerebral palsy, which we can see as decreased balance, decreased coordination, intention tremor. And for basal ganglia and thalamus damage, so it will cause dyskinetic cerebral palsy, which we can see as chorea, atetosis, right? So I will explain more after this. Okay. So we move on to clinical features. So the sign and symptoms. For symptoms, the mother of the children, because commonly cerebral palsy, we usually we try to diagnose for children less than 5 years old. Why? Because if the child, because this disease is neurodevelopmental disease, which means that it doesn't get worse over time. So the symptoms might appear since the child is baby. Yeah, so for example, feeding difficulties, because the child might be having difficulties in feeding due to oral-motor dyscoordination. We can be seen as slow feeding, gagging, and vomiting. These symptoms we can ask to her mother or father lah. And also developmental delay in language and skills. And for signs, the child might be having delayed motor milestone, abnormal limb and tongue posturing, abnormal gait, hand preferences to signify hemiparesis, and also persistence of primitive reflex for more than 6 months. Okay. So now we will move on to specifically each types of cerebral palsy. The first one is spastic cerebral palsy. So spastic cerebral palsy, as I said earlier, it is due to injury or damage in the cerebral cortex. So we know that cerebral cortex is the place where our neuron cell body is located, upper motor neuron cell body located. So when there is damage to cerebral cortex, there will be upper motor neuron lesion that will impair the ability to receive GABA. So we know GABA is important in inhibiting for inhibiting signals. So if GABA is impaired, so there will be hypertonia. So among the major characteristics of spastic cerebral palsy is seizure gait, which adductor muscles continually flexed, and also toe walk, right? Okay, so this is spastic. So spastic cerebral palsy can be further divided into 3 types. So first one is spastic hemiplegia. So you can see in this picture, in this diagram, so it affected one side of the body, either right side or left side. Okay, and usually upper limb more affected than lower limb, but usually both are affected, but upper limb is more severe. And the third one is delayed walking or circumductive gait. So I think if we have more time, I will show you guys a short video for the gait. So for exam findings, this usually we do neuro exam lah for the child. So we will find circumductive gait, and also we can find growth differences of hand and thumbnail, and tiptoe walking, unilateral ankle clonus. For clonus also, I will show you guys a video if we had time. And then Babin's design, wrist deep tendon reflexes, and weak dorsiflexors. All right, so this is for spastic hemiplegia. So second one is spastic diplegia. So diplegia, if hemiplegia is either right or left side, so diplegia is usually it affects lower body, so lower limb, right? So the patients will manifest with bilateral spasticity, okay, and legs usually more affected than arms, and first sign is a commando crawl. So commando crawl usually we can see if in baby. So when the baby crawls, we can usually see that the baby doesn't really use their leg. Instead, they just use their hand. So That is commando crawl. Okay. So for exam findings, we can assess for spasticity of the legs, breast reflexes, ankle clonus, bilateral Babinski sign, scissoring posture of legs, tiptoe walking, and also atrophy and impaired growth of legs in severe cases. Okay. So the last one, and this is the most severe one, which is spastic quadriplegia. So quad, right? So quad means 4 limbs lah, 4 limbs, including 2 upper limbs and 2 lower limbs. So impairment to all extremities. And for this spastic quadriplegia, it is high association with cognitive deficiencies and seizure disorder. And usually, another complications is that this patient will having intellectual impairment or disabilities, and also increased difficulty of swallowing. So it will increase the risk of aspiration pneumonia. Okay. So during exam findings, we will see same increased tone, spasticity, decreased spontaneous movement, breast reflexes and plantar extension, flexion contractures of knees and elbows, and also delayed speech and visual abnormalities. Okay, so we move on to next type. Just now is spastic, so now we move on to dyskinetic or affected cerebral palsy. So affected cerebral palsy usually due to damage of basal ganglia. So basal ganglia is important to initiate and prevent movement. So in affected cerebral palsy, there is no prevention of movement. So it will result in involuntary movement. So we can see the patients can be manifested with dystonia and also chorea. So for dyskinetic, this is less common than spastic because I said earlier, 70% diplegia special to basically of head control and head lag. So now we move on to attack cerebral segment. Cerebral movement.
I think Najiha's internet is not that stable.
Hello?
It's not.
Yes,
Yeah,
same with me.
it's lagging.
I thought I'm the one, but okay, since
Hello.
everybody say, so means it's her problem.
Hello? 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 Me? Can you guys hear me now?
Yes.
Yeah.
Yes.
Okay, I'm so sorry. Where should I start? Sorry. Give me a minute, dia loading. I'm so sorry guys. Sekejap. So sorry guys, sekejap. Dia internet slow. So sorry. Where should I continue? Can you guys hear me?
Yes, yes.
Yes.
Yes, from
Um,
this kind of
This kind of thinking. So okay, I will repeat my presentation. So for dyskinetic cerebral palsy, so dyskinetic cerebral palsy is due to damage in basal ganglia. So basal ganglia is important in initiation and prevention of movement. So if there is impairment or damage to basal ganglia, usually there will be no prevention of movement. Thus, it will result in involuntary movements. So among the characteristics is dystonia and also chorea. Okay. So, okay. So dyskinetic, unlike spastic, so dyskinetic is less common than spastic, which I've said earlier. It comprises of 10% of cases, and seizure disorders is uncommon, unlike the quadriplegia, spastic quadriplegia. So and also the patients usually have normal intellectual development in many patients, and common causes of dyskinetic cerebral palsy is due to basal ganglia and thalamus lesion or chronic teres. So usually if the patients, if a baby is having prolonged jaundice, so we need to be monitored because we know bilirubin can cross the brain and causing complications. Okay, so during neuro exam, so what we want to assess in patients is that for hypotonia and poor head control and head lag, as well as variable increase in tone with rigidity and dystonia. So, and then also we need to assess for feeding and speech difficulties. Okay, now we move on to the third types of cerebral palsy, which is ataxic. So ataxic cerebral palsy is due to lesion in cerebellum. So we know cerebellum is responsible in coordination, fine and precise movement. So for characteristics of ataxic cerebral palsy, if there's any lesion in cerebellum, so patient might present with hypotonia, rigidity, delayed motor movement, and late signs. The patient might have uncoordinated involuntary movement, such as rigidity or broad gait, and also lack control of eye movement and also fine motor skills. So that is for the cerebral palsy manifestations. So now we move on to diagnostic tests. To diagnose cerebral palsy, usually there is to diagnose cerebral palsy, we need to do brain imaging because we need to confirm where the lesion and to where does the lesion extend. So I didn't put in this slide is that before we do brain imaging, we need to assess the patient based on gross motor function classification systems. So we need to assess first the signs and symptoms of the patient and try to classify the patients based on the signs and symptoms. In what classifications does these patients might having? So for example, is this patient might be having spastic or dyskinetic or ataxic, and then we do brain imaging to confirm either there is or there is not lesion in the suspected area. And then for additional tests, because sometimes cerebral palsy might also impair hearing and vision, so hearing and vision testing, also genetic screening for those with congenital malformation and genetic disorder, and also test for thrombophilia if stroke is suspected. Okay. So for management, so cerebral palsy is uncurable. There is no cure for cerebral palsy. Once the patients are diagnosed with cerebral palsy, the patients and their family need to live with this disease. So, but early intervention is very important to improve the lifestyle. So among the management is need to see developmental pediatricians to monitor and promote the child's development, occupational therapists to implement the use of assistive device such as wheelchairs, ankle foot orthosis, and walkers, nutritionists, because sometimes patients with cerebral palsy might have difficulty in feeding. So to avoid malnutrition, the patients need to meet nutritionists and also enteral feeding such as EG tube. And then orthopedic for chronic muscle weakness, and speech therapies to assist with speech development. Also physiotherapies for muscle control, overcoming weakness, minimizing spasticity, and also preventing contractures. Okay. So now for prognosis of patients with cerebral palsy. So it depends on the motor function and motor function type, such as maybe hemiplegia, quadriplegia, diplegia, and depends on severity, because some patients might be having intellectual disabilities, some patients might not. So it may change the prognosis based on the severity of the disease. For life expectancy, most 44% of patients have normal life expectancy, and mortality risk increases with increasing number of impairments such as intellectual, hearing, or vision. And the strongest predictors of early mortality are immobility and impaired feeding ability. So I think that's all from me. Thank you.
Okay, any question from the floor? Okay, so this cerebral palsy is a very, very heavy topic. By right, this 20 minutes also, I think it's very difficult to say everything about cerebral palsy. But in medical context, the most important thing you have to understand, this is a damage to the brain, to the developing brain. So which is very different from the adult stroke. So adult stroke is a developed brain. Okay, so that's why the presentation is very different. So yeah, there's an array of the type of cerebral palsy. You can have quadriplegic, you can have spastic diplegic, you can have your chorioarticoid, ataxic. Okay, so but most of them are severe. Those that maybe will be underdiagnosed or overlooked would be spastic diplegic. Okay, why I say that is, of course, your hemiplegic, your quadriplegic, all these patients definitely will have development delay. Okay, which you will be able to appreciate if you ask the parents. So I mean, you will go through a development milestone, you would have picked up. Okay, but spastic diplegic is the child maybe still can walk, yeah, but depends on the degree of the neuron involvement. Okay, because we do see patient presented to us maybe 5-6 years old, tiptoeing, then only we diagnose patient has spastic diplegic. Okay, and most of them have most of the spastic diplegic may have a near normal outcome, meaning usually their brain function and IQ are quite well preserved compared to the rest. Of course, you notice I keep on mentioning pick up all this problem is because sometimes all these patients they are being followed up at clinic kesehatan. You know, if you don't pick up the developmental delay, then you didn't refer to us, then the early intervention program not started promptly. Okay, so this early intervention program have to start as soon as possible. Ideally should be less than 3 years. That's why it's called early intervention. Okay, so this early intervention, once you started, hopefully you can regain some degree of your the motor function. Okay, because it's as your friend said, it's an incurable disease, so the family have to live with it. But if you may manage to somehow to rehab them early, actually they can gain back some degree of function, which will greatly help a lot to the family. Example, like let's say if the spastic diplegic previously cannot walk very well, so if you intervene early, the child can walk with crutches or maybe can walk with a special shoe. That would actually change the whole scene for the whole family instead of being bedbound or wheelchair bound. Same goes to quadriplegic CP. If you manage to intervene early, maybe the child can sit on the wheelchair well enough, then the family can actually reduce the burden of carrying the child all the time. Okay, so these are the things that you need to look into for this context. But in the theory aspect on which pathway to involve, which organ to involve, what are the causes, this is actually very deep into neuro. I mean, frankly speaking, I'm not a neurologist, but yeah, I mean, you sure should go through it and read yourself regarding the pathway. Okay, anything else want to ask about this cerebral palsy before we go to the last topic? Anyone? You know one, then we move on. Thank you.
Thank you.
So can you guys hear my voice?
Yes.
All right. Assalamualaikum warahmatullahi wabarakatuh and very good morning. So for today's seminar, I will be covering a topic on muscular dystrophy. By the way, my name is Ahmad Ariza Iman, Ratib, with match number 9192475. All right, so for this particular seminar, I will be covering the overview of the muscular dystrophy, the type of the muscular dystrophy, its etiology, and also its classification. And I'll be more focusing on the Duchenne muscular dystrophy, its etiology, pathogenesis, clinical manifestation, differential diagnosis, investigation, complication, and prognosis and management. Wait. Okay. All right. So for the introduction, basically, muscular dystrophy is a group of genetic muscle disorder, it is characterized by progressive myofiber degeneration, and gradually it will replace by a fibrotic tissue and also fat. So over time, when there is a muscle degeneration, so it will causing the patient to have muscle weakness, and it will affect the daily life, which it will decrease the mobility and making everyday tasks become difficult. So basically, muscle dystrophy means muscular means muscle, and dystrophy means this is bad, and trophy means nourished. So if we combine together, the real meaning is muscle poorly nourished. And we have to bear in mind that muscular dystrophy, it is not involved any nerve or neuromuscular junction damage. So we can distinguish between muscle weakness that caused by neuromuscular muscular dystrophy and also nerve damage like neuropathies. All right, so there are 9 major types of muscular dystrophy, which is the first one is Duchenne muscular dystrophy, which is the most common one, and the Baker muscular dystrophy, Emery-Dreifuss, limb-girdle, facioscapulohumeral, distal, oculopharyngeal, and other 2 types of muscular dystrophy, which is not in this picture, which is the congenital muscular dystrophy and also myotonic dystrophy. So a certain type of muscular dystrophy may affect certain area of the muscle weakness. So for the etiology and classification, we can classify the muscular dystrophy into 3 parts, which is the autosomal dominant, X-linked recessive, and also autosomal recessive. So under autosomal dominant, we have facioscapulohumeral muscular dystrophy, myotonic dystrophy, oculopharyngeal muscular dystrophy, and other subtype of limb girdle. And the next one is X-linked recessive, which is we have Becker muscular dystrophy and Duchenne muscular dystrophy, which is the highlight for today's presentation. And the other one is autosomal recessive, which is the limb girdle form. All right, so we have to note that different type of muscular dystrophy may be due to different protein defect. As you can see in this diagram, if there is a gene mutation or defect in dystrophin, it may cause DMD or BMD, which is the Duchenne and Becker muscular dystrophy. If there is a defect in integrin protein, it may cause congenital muscular dystrophy. Same goes to the sarcoglycan complex, which may lead to limb-girdle muscular dystrophy. All right, so a defect on structures called dystrophy, we call it as dystrophinopathies, where we have 2 under the dystrophinopathies, which is the Duchenne muscular dystrophies and also Becker muscular dystrophinopathy. So DMD is a very severe form, and it causes a loss of dystrophin, and the symptoms usually present early at the age of 5. And the next one is Becker muscular dystrophy. It is milder in symptoms, and it causes misshapen of the dystrophin itself, and the symptoms usually present at the age of 10 to 20. Right, so our highlight for today, which is the Duchenne muscular dystrophy. It is most common type of muscular dystrophy and one of the most common genetic disorder of the childhood. So epidemiologically, 1 in 3,500 male infant will be affected worldwide. All right, so as I just said recently, the DMD, which is a Duchenne muscular dystrophy, is affected by X-linked recessive, particularly at site of XP21, which is the spontaneous gene mutation, which occurring in 1/3 of the cases. So in the X-linked recessive disorder will result in deletion of the short arm of the X chromosome, particularly at XP21 sites. So in this SP31 site, the function is to code for a protein that called dystrophin. So the dystrophin protein is function to stabilize the sarcolemma in our muscles. So since it is X-linked recessive, so mainly it will affecting the male. Right, so before we jump into the pathogenesis, as I said recently, dystrophin is function to stabilize the sarcolemma by connect the cytoskeleton of the muscle fiber to the surrounding extracellular matrix through the cell membrane. So you can see this is the dystrophin here. It will connect the actin of the cytoskeleton to the extracellular matrix through the cell membrane. All right, so we jump into the pathogenesis. So we already know the function of the dystrophin. So when there is a gene mutation on the dystrophin, that will lead to a defective dystrophin. So it will cause loss of the dystrophin itself. And when there is no dystrophin, it will causing a myofibril membrane instability. So a patient with muscular dystrophy, when the patient contracts their muscles, it will causing a rip in their membrane muscles, and therefore it will causing influx of extracellular calcium into the muscle fibers. So these muscle fibers will activate the protease in our muscle fibers. So when there's a lot of excessive calcium ion that goes into our muscle fibers, it will increase the activated protease, and hence it will increase the muscle photolysis. So when there is increasing in muscle photolysis, they will progressively leads to muscle degeneration, and it will replace by fibrotic tissue and also fat. All right, so we go to the clinical manifestation. So in infant boy, they are only rarely symptomatic in early pregnancy. All we can see is just a poorly head control, mild slowness in attaining motor milestone. But in clinical onset, which is usually occurring in the age of 2 to 3 years old, where we can see there's a delayed motor development, such as taking longer to learn, to sit, stand, or to walk. And also, usually, the patient usually not begin to walk until the age about 8 months or later. And also, we can see the boy is congenitive and intellectual impairment, and also there is a muscle weakness that getting worse over time. And also, we notice that the patient might have delayed speech and language development. So you can see at the right side of the slide, you can see the diagram, which the boy will come to you. The boy with Duchenne muscular dystrophy will come to you like this. All right, so I will explain it one by one. All right, so the first one is waddling gait. So waddling gait is basically a wide-based gait, which come with toe walking, just like a duck walk. If I can show you, if we have time, I will show you. So the waddling gait is mainly caused by weakness in gluteus maximus and also gluteus medius muscles, where the patient will have the inability to support the single leg stance, and it will tend the child to lean the body toward each other to balance the center of the gravity, by which the motion will be repeated in each step. Right, so the next one is lumbar lordosis. It is caused by the hip extensor weakness. So it will result in forward tilt pelvis, like you can see in this picture, due to the hyperlordosis of the spine in order the child to maintain their posture. So the next one is Gower sign, in which you can see the patient need to using their hand and arm to stand straight because of the weakness in child proximal hip muscles from their position. So the next one is toe walking. So based on the patient, it is easier to stay vertical with an equidistant foot position because of the contraction. But gradually, the child is observed to have increasingly noticeable difficulty to take steps and frequent falls without tripping and stumbling. And next one is progressive enlargement of the heart, where the patient might have dilated cardiomyopathy. As we all know, the dystrophin, dystrophic protein also may be expressed in our heart. So when there's loss of degeneration of the muscle heart, so it will replace by the fibrosis, and it will cause extensive fibrosis in our heart. So it may cause the cardiomyopathy. And next one, same goes to our calf. It will cause enlarged calf muscle, but not hypertrophy, but it is replaced by the fat and fibrous tissue, as we call it as pseudo hypertrophy. And the next one is microglosia. The patient might have large tongue. Right. So later in stage, we can manifest the child to have upper extremity involvement, where most of the child will using a wheelchair by the age of 12, and most of the time the child will die because of the respiratory complication by the age of 20. All right, so the differential diagnosis of DMD includes the Becker muscular dystrophy, limb-girdle muscular dystrophy, Emery dysphus muscular dystrophy, dilated cardiomyopathy, and also spinal muscular atrophy. Right, so we come into the diagnosis and investigation. So we can suspect the patient to have DMD if there is any evidence of delayed motor milestones in a young child with a positive family history of DMD. But if there is no family history of DMD, we can suspect the children to have DMD by not walking by 6 to 18 months, or presence of the Gower signs, tall walking, or calf hypertrophy. So to confirm the diagnosis of DMD, we can you can check the creatine phosphokinase if it elevated from 50 to 300. And also we can use the genetic testing and also muscle biopsy. So in this diagram, we can see there's a normal and affected muscle biopsy. In this affected muscle biopsy, we can see there's splitting fibers, proliferation, and connective tissues, and this adipose tissues present. Right, so next we go to the complication. The first one is the cardiopulmonary failure, where it is caused by decreased heart function and cardiomyopathy, as I said before, and also it can cause by the weak diaphragm, which may affect the respiratory failure. And also another complication that the child might have is contracture and early wheelchair dependence, in which the patient loss of muscle mass and inflammation and fibrosis. And also the complication that the child might have is osteoporosis, fractures, and also scoliosis, where the scoliosis may be due to the poor mobility and increase in muscle weakness that leads to change in the trunk, and eventually it will may lead to progressive scoliosis. All right, so for the prognosis, the child may be improved between 3 to 6 years of age, but then it will follow by gradual and relentless deterioration. But most of the patients will, before the age of 12 years old will lose their ambulation and require non-invasive ventilation by the late of teenage years. However, survival into the adulthood is now very common, but the survival beyond the third decade is very uncommon. All right, so for the management, there is no known cure for Duchenne muscular dystrophy, but our aim is to manage the symptoms and complications, where we can use the straight therapy to slow down the pace of the disease and to delay the motor disability. But we have to note that there is a certain side effect which may include excessive weight gain. And also we can give the supportive care therapy, which is the physical therapy, bracing, and proper wheelchair. And also we can treat the underlying symptoms, which is the cardiopulmonary dysfunction, pulmonary infection. And also we can give systemic counseling to the patient. I think that's all I have to present.
Okay, any question from the floor? Okay, so okay, muscular dystrophy actually is not commonly seen in Malaysia. The more commonest is still Duchenne, basically based on the age of onset. Okay, so Duchenne is usually younger, Becker's are usually older. So Duchenne may be up to 5 years, the symptom will start to arise. Becker's maybe when they go to secondary school. Okay, I think there's one important slide is regarding a few type of the muscular dystrophy together with the area of the muscle that involved. Why I say that's not important? Because basically muscular dystrophy, they presented to you with proximal muscle weakness. Okay, so the clinical sign that you mentioned, like a broad-based gait, Gower sign, actually all those are proximal muscle weakness. You have to understand this disease affect mostly proximal, or basically most of the muscle, but most of the time they will affect proximal muscle. Okay, so they will present to you maybe with gross motor delay. If the more severe type, they will present with gross motor delay, and then but commonly they will come much later because, as you mentioned, the presenting age is 5 years old. Okay, so maybe the child will have a near normal development until then slowly they will get worse by time due to the muscle getting atrophy. Okay, so commonly people will say one of the very significant clinical sign is if you can see calf hypertrophy, but your patient is weak. Okay, this is almost exclusive to muscular dystrophy. Okay, that is due to your muscle being replaced by fibrous tissue. Okay, not become what I call this, not atrophy like the muscle bar getting smaller. Okay, because you also mentioned this is purely muscle problem, no CNS problem. So that's why your muscle you didn't see the muscle actually shrink. In fact, the muscle get more bulky due to the fibrosis. Okay, of course, as the child age, then the more and more muscle tissue being lost, then we try to prevent it by giving steroid. Okay, in Malaysia, I have a neuro clinic early next month. Okay, then if you are still here, maybe you all can go and see. I think I definitely have a handful of muscular dystrophy patient. Okay, then you all can see and appreciate what is the Gower sign, what is the broad-based gait. So under neuro, they will start on steroid to prevent the further breakdown of the muscle. But as you presented, this problem is due to the abnormal dystrophin. So the damage will still be ongoing. So as the child progresses, then the child may become cannot walk, bedridden, wheelchair bound. Then when they start to affect the heart, when they start to affect the diaphragm, and this is the time that the child become terminal because the body no longer can cope with the body demand. So sometimes we will start on patient on non-invasive ventilation, like a CPAP, BiPAP. So some of the picture you adopted, you saw the child was on the tubing at the nose with the wheelchair, right? So this is ideally how we do for the child. But yet again, the prognosis overall is not very great. It's about second to third decade of the lifespan only. Okay. So yeah, it's quite a very heavy topic today. I think especially for cerebral palsy and muscular dystrophy are very pure theory. So there's nothing much to elaborate on it. So I hope you all can benefit from your CME today. Okay, is there anything you guys want to ask before we end this session? Anyone? If no one, then I will say, yeah. So then I will end this session. Is it okay?
Okay, Dr.
Okay, Doctor.
Okay, thank you very much.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you so much.